I am now presenting a video about the tissue plasma activator injection subretinally for submacular hemorrhage to make it easy and simple. Tissue plasma activator present in the market, in the pharmacies, in 2 bottles, 1 powder, 1 distilled water, and we can dissolve the distilled water in the powder to make a solution containing the tissue plasma activator, and with parameters and doses, specific doses, we can extract the needed dose to inject it inside the subretinally, inside the vitreous subretinally to resolve the submacular hemorrhage presented after maybe CNV or trauma or any of the causes. We can dilute it and extract the specific dose that you need and use it intraarterially. I want to say, and we have the instruments that we are using here is specific instrument for the specific cannula, which is from DORC. It is 41 gauge cannula with insulin needle, syringe, and the tissue plasma activator as a material. Before you use it, you have to test the syringe like this. We have 2 ways to inject the material subretinally. Either you use it all in one, because the 3 main steps for subretinal injection is: first, you induce the retinal detachment, or just to say the macular detachment by the ringer lactate. Second, you inject the material, which is the tissue plasma activator. Third step is to inject air to make a gravity effect to dissolve the blood. Some schools say that you can put these 3 steps in one syringe and make it in one-step procedure. I don't prefer like this because it's not controlled, but I do every step by a different insulin syringe. This is for me better controlled. So here we test the injector, and let's start the surgery. The surgery is beginning now. After the anesthesia, I do here the PVD, the vitreous. Then we are staining the vitreous by Kinacort for better visualization. After doing core vitrectomy, shaving, for me, when you enter the vitreous is pathologic. You have to remove meticulously all the vitreous from the center by core vitrectomy and from the periphery by careful shaving. And then we start here our first step, which is injecting or inducing the detachment. Now we are inducing the detachment. When you displace the retina from its place, the second step here is to inject the tissue plasminogen activator, piercing the retina slowly and patiently, and you inject the material. The third step here is to inject the air bubbles, like what you see here. In this procedure, you should be very slow, because in this stage you may rupture the fovea, may rupture the macula. But what is in favor of us that the ILM is present, and this is the pre and post injection after 1 week of the procedure. And the patient is happy. Maybe vision was improved by 5 millimeters. This is the second video about macular hole. This is the pre-operative OCT. In macular hole, usually we have three main steps that you do. It is PVD, vitrectomy, the ILM, and using SF6 gas to tamponate the flap that you did. Fortunately, Dr. Omar presented many cases of macular hole. It was very good and very nice. I am presenting here the inverted flap for you. This is the steps for the surgery is to change air fluid level. We change to air. This step is important to make the stain the macula very perfectly. Some use staining with fluid, but this is not good. I am prefer to change to air fluid and stain. This is better for better visualization. Here we are doing ILM peeling with multiple flaps. Then we use cutter in a shaping mode with the lowest cutting rate and aspiration rate, because if you are not cautious, you may remove the flap from its place and you will lose the case. So here it is very important. Now we are changing to air. In this step, it's very important that you have to have the valved trokers, because when you change to air and you remove it, you change it to air, if your valve trokers are not valved good, maybe the turbulence that occur inside the vitreous also may make pressure on the flap and you lose your flap again. So we okay. After all this, we finish our procedure by removing the trokers and injecting gas SF6. I am preferring to inject it by 2 needles, controlled, more controllable, and we check by our fingers the pressure to not more inject, overdose the gas. The take-home message here is you have to be prepared with every instrument that you have in the operating theater, and you have to plan for yourself what you are doing, because in VR surgery you have to be a very good pre-assessment for the, and this is the picture of the post-op after 1 week, which has very good result and the patient was very happy. You have to be very well planned, very well, you examine your patients pre-operatively, very good assessment to know what you are doing inside every step. And you have to have the plan Bs for your surgeries, because sometimes the plan A is not working, you have to change to the second plan to make your operation successful. Thank you very much for having me here. Any question? حبيبي يا رشيد.
I need to add a little bit for anyone who has some knowledge I think you just need to inject the TPA. From my experience, the reduction of retinal reduction, the reduction of subretinal layer have no rule. I would believe that the sure just injecting the basis to do a matter reduction, and then you do a multiple injection of TPA and you do the injection of subretinal layer. But when I checked for just 0.1, 0.2, maximum 0.3 TPA injections, it will be more than enough. And don't forget to inject this TPA in a junction between the subretinal blood and the attached retinal. This is the point that will be easy to be injected. And this is the.
Thank you very much. This is a very good point, because when you are reaching to the third step by injecting air, you are sweating, you're sweating because you are afraid that there may be a rupture or something like this, but your point is very good.
Make it simple. Less is more.
Yes.
Make it simple. Less is more.
Thank you very much.